biomedical engineers are assessing the damage to medical equipment to determine what we can provide to ensure continuity of care. We will also provide medical supplies to hospitals that have received patients from Ahmadid, including the attack on the Children's Hospital. WHO verified 4 attacks on healthcare in Ukraine on Monday, killing 9 health workers and patients and leaving another 71 injured. Since the beginning of the war, WHO has verified 1,885 attacks on healthcare, which have been linked to 157 deaths and 435 injuries among health workers and patients. Attacks on healthcare are a violation of international humanitarian law. Next to Sudan, which has endured 15 months of conflict with almost 19,000 people killed and 33,000 injured. Access to health services continues to be severely constrained due to insecurity and shortages of medicines, medical supplies, and health workers. Almost 15 million people need urgent health assistance, including maternal and newborn care, treatment for cancer, diabetes, and other non-communicable diseases, and protection from outbreaks of cholera, measles, malaria, dengue, meningitis, and more. The risk of famine is growing, with more than half Sudan's population facing crisis levels of food insecurity or worse. WHO has recently distributed 3 metric tons of prepositioned supplies to meet the critical needs of the population in North Darfur. We call on both sides to the conflict to facilitate assistance for those in need. Opening the Adre crossing from Chad into Western Darfur is absolutely vital for scaling up assistance. Access must also be facilitated elsewhere, including to Khartoum, the Kordofan states, and other hotspots. Renewed fighting has forced even more people to flee. In the past 3 months, the number of displaced people has increased by more than 45% to 12.7 million, including 10.5 million who were displaced internally and 2.2 million who have sought refuge in neighboring countries. Their health needs are enormous. In Chad, most arrive after multiple displacements, suffering gunshot wounds, many having survived rape and sexual violence without sufficient food for months and having walked for days. Host communities in Chad have been very hospitable, offering food, water, and shelter for refugees, but the needs are overwhelming. Last week, WHO experts from our Eastern Mediterranean and African regions conducted a joint mission to Chad to assess the refugee situation and scale up cross-border operations. Our priority is to create systems that address immediate medical needs, but also strengthen Chad's health system capacity so the health needs of refugees are not dependent on aid in the long term. Despite the increasing health needs in both Chad and Sudan, WHO has only 18% of the funds we need to meet those needs. The international community must do better than that. Sudan remains a political crisis that can only end with a political solution. Peace, access, and funding are in desperately short supply. And once again, it's the innocent who suffer. Finally, to Gaza. Since the conflict began in October last year, more than 38,000 people have been killed, 88,000 injured, and about 10,000 are missing. More evacuation orders issued by Israel are further threatening the health of people who have already suffered so much. The Al-Ahli and patient-friendly hospitals in northern Gaza are the latest that are unable to function because of fighting nearby. Patients from Al-Ahli have been evacuated to the Indonesian hospital, which is now operating at 3 times its capacity. Over 10,000 patients still need medical evacuation for treatment that cannot be provided in Gaza. Multiple evacuation corridors are needed urgently to the West Bank, Egypt, and Jordan. And almost the entire population of Gaza now faces high levels of acute food insecurity. Almost 1 in 4 are facing starvation, and another 1 in 3 face acute malnutrition. At the same time, very few supplies are getting into Gaza. Only 5 WHO trucks were allowed into Gaza last week. More than 34 trucks are waiting at the Al-Arsh crossing, and 850 pallets of supplies are awaiting collection. A further 40 trucks are waiting at Ismailia in Egypt. WHO calls for the restrictions on supplies entering Gaza to be lifted immediately. The people of Gaza, who have nothing to do with this conflict, must not be the ones who pay the price for it. To say more, I'm pleased to welcome WHO's Regional Director for the Eastern Mediterranean, Dr. Hanan Belkhi, who visited Gaza and the West Bank last week. Hanan, thank you for joining us, and you have the floor.
Thank you very much, Dr. Tedros. Good morning, good evening, and good afternoon. As you've heard, the Director General has said, I have just returned from the occupied Palestinian territory, where I visited the West Bank, including East Jerusalem, Jenin, and Gaza. The situation in Gaza is concerning on both a human and humanitarian level. I saw firsthand the scale of devastation, lives and homes in ruins, hospitals overwhelmed, and a fully destroyed city. Lack of fuel is compromising all health and humanitarian operations. Running sewage and garbage litter demolished streets with the smell of fermented waste permeating the air. This situation is providing the perfect breeding ground for diseases to spread, leading to an increase in cases of acute watery diarrhea and acute respiratory infections, among many others. Ongoing violence and the breakdown of law and order are devastating an already crippled city and creating an extremely high-risk environment, not just for aid workers, but for everyone in Gaza. The breakdown of law and order also makes it nearly impossible to manage gender-based violence, exposing displaced Palestinians to additional life-threatening risks. I met with WHO staff in Gaza, many of whom are national staff who have faced personal loss and suffering. Despite these challenges, they continue to risk their lives to deliver fuel and medical supplies to hospitals and transfer patients to safety and care, striving to overcome delays and obstructions along the way. As a result of increasing hostilities and soaring needs, WHO has expanded its medical supply chain for Gaza. However, much of this aid remains stuck on the wrong side of the borders, with only a fraction reaching Gaza. And even when supplies do enter Gaza, the breakdown, again, I repeat, of law and order makes it challenging for our teams to deliver them to hospitals that urgently need them. I visited the IMC field hospital in Deir Balah, which has relocated twice and tripled its capacity over the past few months. There, I met severely malnourished 7-year-old Jannah, who was evacuated from Kamal Adwan in the north 3 months ago and is still waiting for evacuation outside Gaza. Jannah is one of more than 10,000 patients in need of specialized care outside the Strip, yet who remain unable to exit since May 7th. Their conditions range from trauma injuries to chronic diseases to others. In my meetings with Muhannad Hadi, UN Deputy Special Coordinator and Resident Humanitarian Coordinator for the Occupied Palestinian Territory, and Tor Wennesland, the UN Special Coordinator for the Middle East Peace Process, we agreed on the need for immediate action to address suffering in Gaza. We need member states to swiftly fulfill their global diplomacy mandate and expedite an immediate truce. We need all borders, including Rafah border, to open and allow fuel, medical supplies, and other essential humanitarian aid to flow in. And we need those who require medical care to be able to exit. Before October 7, despite the need for permits, Gazans were able to seek medical care in the West Bank, including East Jerusalem. This access to care must be restored, and those who need medical care in other countries must be allowed to exit without further delay. Gazans need more than just food, water, and medicine. They need protection, peace, and security. One man told me, we long for a ceasefire, for a chance to live without fear. And a woman told me that she has one question for the whole world to answer. Do you consider us human? She asked me 3 times. During my 11-day visit, I traveled to the West Bank, where I saw a rapidly worsening health situation. At Jenin General Hospital and the UNRWA clinic, I learned about health workers killed or injured due to repeated attacks and saw extensive damage to infrastructure and medical equipment. With damaged roads and restricted access, WHO and partners, including the Palestinian Red Crescent Society, have set up mobile medical services to reach people at the point of injury. At Jenin General Hospital and 6 other West Bank hospitals, WHO has supported mass casualty management training and response planning. Our goal is seamless and effective trauma care across all levels based on lessons from Gaza. As we support the right to health for all Palestinians, we must also work to strengthen already fragile health systems in neighboring countries, including Jordan, Lebanon, and Syria. We are extremely concerned about the escalation of violence along the border between Lebanon and Israel, resulting in increased deaths and injuries among civilians and health workers, displacement, and damages to health infrastructure. In our region, entire generations have grown up knowing nothing but conflict and deprivation. Addressing the root political causes of these emergencies is not just a humanitarian necessity, but a strategic investment in regional stability and security. Thank you very much, and back to you, DG.
Thank you very much, Hanan, and really appreciate your leadership. And Tariq, back to you.
Thank you very much, Dr. Tedros and Dr. Balkhi. We will now open the floor for questions, and we'll start with Helen Branswell from STAT. Helen, please unmute yourself and go ahead.
Thank you very much, Tariq. My question is, I'm sorry, about H5N1 in cows in the United States. I'm wondering if, probably this is for Dr. Ryan, I'm wondering if it appears at this point like the virus can be driven out of cows. Do you have thoughts about that? Thank you.
Thank you very much, Helen. We will start with Dr. Maria Van Kerkhove, who is online. Dr. Van Kerkhove is the Director at Interim of Epidemic and Pandemic Preparedness and Prevention Department. Dr. Van Kerkhove.
Thanks, Tariq. Just checking you can hear me okay.
We can hear you.
It says my connection is unstable. If I have a problem, just let me know. Thanks, Helen, for the question. I think you asked something similarly a few weeks ago. The question of whether it can be driven out of cattle is an important one, but I think I'll give a similar answer to what I did before, and that we really need to understand the extent of the circulation in the dairy cattle before we can say if it can be driven out. Certainly with more species being infected, we now have, the latest data that I have is 145 herds in 12 states. I think that's only going to continue, given that we've seen some expansive spread, given that we have some limited sampling that's happening in the dairy cattle, not just in the US, but globally. We're working with FAO and with WOHA to have better surveillance globally to really understand the extent within dairy cattle across the globe, since we have such a massive epizootic in wild birds and in poultry itself. So I think that's a complicated question. Doesn't mean that it couldn't happen, but I think before we could get to an answer of when or if that could be possible, we really need to understand the extent. And as the DG has said, our concern is around people who are occupationally exposed to these dairy cattle, to wild birds, to poultry, to infected animals, to make sure that they have and use personal protective equipment. And we know that that is challenging across many different types of climatic zones, and that they get the appropriate testing and care that they need. So I think we don't have a full answer to that question yet. And I think we need to understand much more about the circulation before we can provide you with a more thorough answer.
Yeah, I think when you have a disease, and I'm sure our colleagues in FAO and WAHA would have a comment on this, but within domesticated species, you often have a better chance of pushing a disease out of a particular population, because you have access to that population, you know where they are, and you can apply the biosecurity measures and the public health or veterinary health measures to drive any particular virus out. That can be through treatment, it can be through vaccination, it can be through classic measures that you've seen with Ebola and COVID and others in humans, of isolation, of quarantine and various other measures, but you can reduce the force of infection. And in some cases, you can push a disease out of a domesticated animal population. The difficulty is when that disease then exists in pockets of wild animals, and this is what we see with avian influenza. You can keep poultry populations free of disease, but the next season comes along, there's mixing with wild birds, and then the cycle starts again. So once you push a disease out of a particular pocket of a population, then you've got to protect that population afterwards. And therefore, there's an ongoing process that's needed to preserve that disease-free or infection-free status for that population. And that goes back to what Maria's saying. Unless you understand the population, those animals, is it properly regulated? Do you know where all those animals are? Do you have surveillance in those animals? And then do you have the capacity and the resources to be able to apply for a long period of time a public health or a veterinary health intervention that will be monitored over time that will tell you that you're pushing the disease out of that population? And do you have measures in place to prevent that population being reinfected? So infectious diseases in animals, very similar to infectious diseases in humans, very similar dynamics. It is relatively more easy, and we've seen with diseases like rabies, very difficult to eliminate rabies as a public health problem for humans, because you get the disease not only in domesticated dogs, but you find that, for example, feral dogs and others can continue to carry the infection. So therefore, there's always a risk back of reintroducing introducing the disease into animals or having humans being affected. So it's all the more difficult when you have other potential reservoirs for the disease outside the domesticated animal population. So it requires a very strategic approach. It requires very close cooperation between veterinary services, not just domesticated veterinary service, but wild animal services, surveillance across that, not just the animal-human divide. And we talk about this animal-human interface in One Health. There's an animal-animal interface, very often between domesticated and wild animals, and that's very poorly managed at times as well. This requires an integrated, multi-sectoral, long-term response where we identify the threats, we monitor those threats together as services in the veterinary, wildlife and in the public health arena, and we apply long-term public health measures to be able to reduce the risk of infection, push disease out of populations where we can, reduce the risk to minimum where we can't get the risk to zero, and then maintain good biosecurity over a long time. That requires policy, investment, long-term commitment, surveillance and cooperation. And unfortunately, in the world where we look for silver bullets and the treatment that will cure everything, unfortunately, the treatment for most of our ills as a human civilization is cooperation, policy, resources, and the will to do the job.
Thank you very much, Dr. Van Kerkhove and Dr. Ryan. I hope this answers the question. And now we will go to Christian Ulrich from DPA, German news agency. Christian, you have the floor.
Thank you, Tarek. My question is on MPOX. I don't know whether Rosalind is online or maybe Mike Ryan can otherwise answer. Because I have only one shot, I need to stagger this into two parts. The first one is today, 25 cases in Goma detected. Can you say something about that? Do you know whether this is clade 1 in general or whether it's the new variant that has been so concerning? And the second half of my question is, how worried is WHO about a spread of this new variant beyond the region, elsewhere in Africa and specifically to Europe? Thank you.
Thank you very much, Christian. Indeed, we have Dr. Rosamund Lewis, our technical lead for MPOX online, and maybe we can start with her. Dr. Lewis, can you please unmute yourself?
Thank you very much. Thank you for the question, Christian. Yes, we are aware of the increasing number of cases of MPOX being reported in Eastern Democratic Republic of the Congo. An outbreak began there in a health zone called Kamituga last September and has been continuing to spread to more than 10 health zones, in South Kivu since then, and over the last couple of months in North Kivu as well, in 3 health zones, including now in 2 facilities, camps for internally displaced persons. So we are aware of this outbreak. We're indeed very concerned about it. The risk of ongoing spread, to answer your question on the first clade, on clade 1, the outbreak in the eastern part of the country is this new strain. And that is the one that is so far found in South Kivu. And I think one case may have been sequenced, the genetics of one virus for one case may have been sequenced in North Kivu. So far, it remains the same strain as in South Kivu. So that is the new strain, which is transmitting so far exclusively from person to person. There's no indication of any link to a zoonotic event, no contact with animals. So this is a strain that is transmitting from person to person, largely through sexual contact initially, including among sex workers, and increasingly in the community as it spreads from health zone to health zone. So there is a response ongoing. However, WHO, of course, is concerned about this. There is a risk of cross-border of the virus continuing to move because those borders are very porous with neighboring countries, Rwanda, Burundi, even perhaps Uganda. There's clearly a lot of population movements across those borders, large-scale population movements for internally displaced persons. These all bring their own associated risks in insecure settings where that's the case, but also the fact that not all cases are reported, not all cases are necessarily detected. So WHO is working with national authorities at both national and provincial level as well as local level to expand access to diagnostics to identify cases both clinically as suspected or reported cases, as well as laboratory confirmation of as many cases as possible. In that part of the country, the proportion of cases that are laboratory confirmed is very high, and the proportion of those that are tested that turn out to be also clade 1 monkeypox virus is also very high. So we're confident in the data that we're seeing and need to continue to support the Ministry of Health for a robust response in that region.
Thank you very much, Dr. Lewis. Dr. Van Kerkhove, would you like to add something?
Yeah, just to reinforce some of the messages Rosamund had just said in her answer on the latter part of the question around our concern around more broader spread. MPOX has not gone away. And you see the monthly reports that we put out. We look at what's happening across the African region. We live in an interconnected world. So the spread of this virus can continue to happen. And that is something that requires strong surveillance. I think, as Rosamund has pointed out, what we see in the DRC within the country itself, there are different outbreaks that are happening. There are reports coming from South Africa, but certainly in neighboring countries to DRC, we wouldn't be surprised if there were MPOX cases that are there. What I think is really critical is that the countries have the support that they need for good surveillance and that they report these cases so that the right interventions can be provided to help people, to prevent the infections themselves, to provide the appropriate clinical care and risk communication, and to ensure that the interventions that do exist are being used. So we are concerned. MPOX is no longer a public health emergency of international concern, but as the DG has said many times, the threat has not gone away. We can't drop the ball on this. We can't lose sight on what is actually happening. Rosamund's pointed out a number of different areas where we, through our regional offices and country offices, are supporting, but we need much more attention to this. If I'm cynical, we can see what happened when we saw cases across Europe and the world started to pay attention. We need to make sure that in the world that we live in, that we have enough focus, enough energy, enough investment across the African region. So this is something that we are working very closely on. And we want to make sure that the countries have the support that they need to help the people that we serve in country. Over.
Thank you very much, both. I understand that Christian has a follow-up. Christian?
Thank you very much, Tariq. I just wanted to ask about this last point. How worried is WHO that this new variant is spreading to Europe? Thank you.
Mike?
Yeah, thanks. I think we're always worried when any disease potentially crosses a border, be it in Africa, be it Europe, be it around the world. And we did see how MPOX spread quite rapidly around the world in the previous event. But also what I would say in relation to that previous event was how certainly impressed I was with the way in which governments reacted, but more importantly, the way in which the communities affected reacted. We had a chance to shut down transmission of that clade 2 virus around the world. We could not take a vaccination approach. There wasn't enough vaccine. It required a classic public health approach of surveillance, recognition of the syndrome, engagement with the community affected, participation and partnership with that community, responsibility, transparency, openness, understanding, and a collective will to reduce the risk of anyone getting this infection or dying. And I think it's been a remarkably successful effort on behalf of the community that was mainly affected in doing that. It showed huge commitment and responsibility. And I think in this particular case, in this situation with MPOX, I'm very confident that that community would again, if that disease were to spread amongst men who have sex with men, that there's a high level of awareness in that community, a high level of experience now in dealing with this infection, in monitoring it and in taking action. I think the concerning thing from the perspective of the clade 1 MPOX, and Rosamund referred to it, is not having a complete understanding of the dynamics of community transmission at this time in the likes of Congo. Rosamund mentioned that this was a disease that primarily started amongst sex workers, men who have sex with men within that particular community, but there is broader community transmission. So the question is this disease more transmissible or transmissible in other ways to the clade 2 virus? So therefore, is it likely to extend further, involve other elements of the population, and in that sense have more opportunities both to spread within a country and to spread between countries, and also be more complex in terms of getting the kind of concerted effort that was managed in that global community to reduce the risk of infection. So there are real questions here. This should be a relatively straightforward disease to control through classic public health measures and interventions, especially with the addition of vaccines. But a disease like this spreading in communities who have trust issues with government, spreading in communities that don't have good surveillance or public health intervention, spreading in communities that have poor access to health. So quite frankly, I am way more concerned with a disease like this spreading to that context than necessarily spreading to a European context where all of the basic services and skills are in place to be able to deal with this. So I would have a general concern. And that's why it's really important that we support the countries currently affected to better understand the transmission dynamics, to better understand how best to control this, to support them in controlling this disease, and have them, we hope on our behalf, around the world, be able to put the investment in place to support the DR Congos and others to control this disease on behalf of us all. Waiting for this disease then to spread to a number of other countries is going to result in a huge extra cost in doing that business. And this is the classic conundrum of epidemics, and the requirement in the IHR is to assist each other in dealing with small outbreaks before they become large outbreaks, before they become huge epidemics, and ultimately before they become pandemics. So I would say, yes, there is a risk of the disease transmitting to Europe. That would not be my biggest concern. My biggest concern is this disease extending in communities that have a high degree of poverty, high degree of underservice in healthcare, and who might have issues in trusting government services. Over.
Thank you very much, Dr. Ryan. We'll now move to our next question, Nina Larsen from Agence France Presse. Nina, please unmute yourself.
Yes, thank you for taking my question. I wanted to ask about Gilead's lenacapavir. Can you hear me? Sorry.
Yes, we can hear you. Please go ahead.
Okay, great. Thank you. Yeah, I wanted to ask about Gilead's lenacapavir, where trial results have shown very high efficacy in preventing HIV infections, but where the current price tag is looking so high that this potentially game-changing drug might be out of reach for many. I was wondering if what your view is on the potential for this drug, and also what you think would be the best way to ensure equitable access. Thank you.
Thank you very much, Nina. I will turn to Ms. Michelle Rodolphe from our Department for HIV AIDS. Michelle, can you hear us? Could you please address this question?
Yeah, I can hear you fine.
Please go ahead.
Sure. Thanks, Tarek, and thanks, Nina, to you as well. So just in response to your question, WHO is extremely excited to learn about the results from the clinical trial of long-acting injectable cabotegravir for PrEP, also known as pre-exposure prophylaxis. This injectable version of PrEP requires just 2 injections per year and has shown incredible efficacy among cisgender women in Uganda and South Africa. In fact, in the trial arm for lenacapavir, there was no infections acquired. WHO is also looking forward to the trial results among men to be shared later this year. So all medicine, whether used for treatment or prevention, should be made accessible as quickly as possible. And the HIV response has a long tradition of ensuring treatment access around the world through the engagement of high-quality generic manufacturers, market pressure, and volume purchasing to help bring down prices. WHO supports greater access to treatment through quality assurance and in-country registration, and through working with funding partners like the Global Fund and with low and middle-income countries to strengthen the local development, manufacturing, and distribution capacity. Generic competition could be fostered through voluntary licensing, voluntary technology sharing, and addressing intellectual property barriers. All people should have the right to access life-saving health commodities wherever they live. Regarding the price has not been published by Gilead for what it will cost in low and middle-income countries, so we can't comment on the price. And in fact, the only information that WHO and the rest of the world has is a press brief from Gilead. So as we've done in the work on long-acting injectable cabotegravir, which is given every 2 months, WHO has been actively engaged in working with other stakeholders and partners to pressure ViiV, a subdivision of GSK, to push down the price. We'll be doing the same with Gilead as well. I hope this answers your question, Nina. Over.
Thank you very much, Michelle, and I hope this answers the question indeed. And let's move to next question. And we have the Nigeria Standard newspaper and Palang Kasmi with us from Nigeria. Palang, can you hear us, and can you unmute yourself and ask your question?
Okay. The issues I wanted to raise, Dr. Michael highlighted some of them, which is concern about MPOX coming to sub-Saharan Africa, and also Nigeria. You know, there's a practice in the country where people enjoy eating even wild animals in form of bushmeat and things like that. So is there a concern that the MPOX spreading of the spread here, and what we journalists need to concentrate on preventive tips and advice to people to understand that this outbreak is spreading. And here, particularly in just Nigeria, Plateau states, you know, many IDPs have been displaced by conflict, and they are also engaging in some of the practices that could be unhealthy. So what advice would you have of concern, just as Dr. Michael raised, that the concern is not Europe, but Africa, sub-Saharan Africa, where our health, you know, even healthcare, access to it is a problem, and other issues like that. Thank you so much.
Thank you very much for being with us today. On a practical advice, maybe Dr. Ryan.
Just very briefly, I wish we had Chikwe here. He would probably be able to give in his experience in Nigeria. But yes, Nigeria is a huge country. It faces many health threats coming from various sources, infectious diseases, natural hazards, conflict, and the Nigeria Centre for Disease Control does a great job in monitoring those threats. MPOX is present in Nigeria, and it has been the clade 2 viruses have been there. Rosalind may wish to speak to that. But there are other threats like Lassa fever and others that come from zoonotic sources. So in general, there are many threats that come from wild animals and the trapping and trade in wild animals, and improper preparation or cooking, or infections during the butchering of wild animals for sale. So there's a general problem in terms of bushmeat, and the biosecurity aspects of that. There are many diseases in the animal community, many diseases that we don't understand or we don't know. And in many ways, when we interact with that wild animal community and we do that unsafely, we can bring disease. it's very important that that any meat from any source is properly cooked and properly prepared to reduce the risk of disease transmission, and that's done in most cases. So we could have a long conversation about this, but there are many zoonotic or animal threats to human health. It requires good food safety practices, good management of markets, very strict regulation of bushmeat and sort of wild meat trade, so that it doesn't become a risk to human beings. But in this particular case, I think the risk to Nigeria of Clade 1 virus arriving is there, but the bigger issue is the fact that there are ongoing problems or ongoing risks in Nigeria that are related to meat from wild animals that are much more pressing and probably much more important. But maybe Rosalind wants to comment.
Thank you very much,
Thank you
Dr.
very
Ryan. Do we have anyone else who would like to add something? Maybe Dr. Lewis or Dr. Vankerkov, or?
Sure, I can add something.
Please.
Thank you very much for the question. It's a very relevant question and really important advice. Thank you, Dr. Ryan, for providing that overview of the sources of zoonotic exposure to monkeypox virus from animals, whether it be trapping and hunting or whether it be consumption of bushmeat, all of which do represent important risks. Notably, in the context of Nigeria, it's been difficult to identify how much of what proportion of cases are from exposure to animals and exposure to the virus that way, or what proportion are due to exposure from human to human transmission. Let's recall that also during the outbreak in Nigeria, which began in 2017, that was the first time in 38 years that Nigeria had ever reported a case of MPOX. And so the outbreak that began there in 2017, 2018 reported hundreds of cases. And even at that time already, sexual transmission was suspected by clinicians and scientists in the country. This is what eventually led to the global outbreak. It was the Clade 2B strain that emerged from Nigeria through sexual transmission. At the time, it was less easy to identify that this was a risk because it had never been reported before. Now we are seeing that sexual transmission of monkeypox virus is a risk pretty much anywhere. We've seen it with Clade 2 globally, of course. We've seen it with Clade 2, again, Clade 2B as well in Nigeria. We've seen different lineages in different parts of the world, all linked to sexual transmission. Now we're seeing Clade 1. So it is correct that the risk of Clade 1 arriving in Nigeria is low at this time. But sexual transmission clearly can happen with all of these various strains of the monkeypox virus. So the important thing is that the people at risk and the areas at risk should be aware, and key messages are important to provide to the community, whether it's the community of hunters and people working with animals, or whether it's the community in people who are exposed through sexual contact. It's complex to provide different messages to different communities, but that is the work of risk communication and community engagement, and critical work so that people identify their own level of risk and protect themselves, to take the right actions to protect themselves from their own risk. And in addition to that, important to raise awareness among clinicians, because regardless of the source of exposure, the healthcare worker has to be able to identify what looks like MPOX and may be different from other rash and fever illnesses, and therefore also be able to request diagnostic testing and confirm the diagnosis. So case investigation is really critical so that each individual case, the sources of exposure, sources of possible onwards transmission, contact tracing, all those public health interventions that Dr. Ryan has referred to, and then also really identifying what are the messages to the community, increasing surveillance, and so forth. So Nigeria is the first country in Africa to have also issued regulatory approval for emergency use of vaccines, and is also working towards development of immunization strategies. That's still a little bit in the future, but as Dr. Ryan has mentioned, will be an additional tool that can be added to the robust public health response that involves clear diagnosis, surveillance, and risk communication.
Thank you very much, Dr. Lewis. We have time for one or two more questions, so I will call on Gabrielle Emmanuel from National Public Radio to ask the next question. Gabrielle, please.
Yes, thank you very much. I had two quick questions. One was just to follow up on the MPOX. I wanted to find out where countries are in terms of using the vaccine, particularly the DRC, and what's available in South Africa. The other question is unrelated, but I was interested in an update on the situation on dengue. I know things were bad at the beginning of the year and would love to know where things stand now. Thank you.
Thank you very much. So let's start then first with MPOX. I don't know, Dr. Vankerkov and Dr. Lewis, would you like to add something on vaccines in particular?
Yeah. Sure. So in order to ensure access to vaccines, which is a critical countermeasure we've just discussed, for the MPOX response, there are many steps that need to be taken. So there's policy guidance that needs to be provided, and WHO Strategic Advisory Group of Experts on Immunization has provided that guidance at the global level. That is then taken up by the regional immunization technical advisory groups, and that discussion has happened in the African region. And then at the national level, there are national immunization technical advisory groups. In the cases of both the Democratic Republic of the Congo and South Africa, both those countries have already received advice from their respective independent national immunization technical advisory groups. Following that is the next step, which is regulatory approval for emergency use, or they have different ways in which they can do that, and different pathways they can follow to undertake their own vaccine assessment at their national regulatory authority. So for the Democratic Republic of the Congo, that has been done, and the Democratic Republic of the Congo has issued temporary authorization for emergency use of LC16 MPOX vaccine and MVABN MPOX vaccine. So they have authorized both. For South Africa, that vaccine assessment process is still underway, and no conclusion has been provided yet from the national regulatory authority. After that, of course, once you have approval securing the vaccine, that's where the global partnership can come and help support different ways, methods to procure vaccines. And that is also work that is underway with our partners, including UNICEF and Gavi and others, member states who are also offering support. And then in addition to that, the countries have to, of course, develop their vaccination strategies. So I can say that for both the countries you've mentioned, the vaccination strategy development has been underway for some time, for the DRC longer, of course, for South Africa since May, when they first experienced the beginning of their outbreak. So those strategy development exercises are underway, and we're moving along that chain, as it were, and hopefully soon, within a matter of a few months at most, we hope to be able to support those countries to actually implement rollout of immunization strategies that they wish to put in place.
Thank you, Dr. Lewis. And maybe Dr. Van Kerkhove, a few words on the second part of the question on dengue fever.
Yeah, thank you. So thanks for the question on dengue. It certainly is a big concern of ours. This year alone, we've had more than 6.5 million cases reported. And this is up from last year alone. We have a problem with surveillance. I'm sorry, I said that wrong. Last year, we had 6.5 million cases reported. This year, from January to May, we've had 9.6 million dengue cases reported. These have been reported from 88 countries across 5 different WHO regions. Most of these have come from the Americas, but we do have very good surveillance in the Americas. What we're trying to make sure is that we have good diagnostic tests around the world so that we can have earlier case detection, we can have earlier clinical management to be able to prevent those severe cases. As you know, with climate changes, with El Nino, with El Nina, we are seeing some differences in the geographic range of the vectors, of the mosquitoes themselves. They're not only affecting the tropics, they're moving further north, they're moving further south. Right now, we estimate that there's about 4 billion people at risk, and that's only going to increase with the changes that we're seeing with climate. So dengue is a significant problem. This is a grade 3 emergency internally for us at WHO in terms of our operational response. It's affecting all of the regions of the globe. We are doing quite a bit of work to improve surveillance, to improve clinical care from those who are suffering, but also to work on risk communication, community engagement, vector control in particular, to make sure that we prevent the cases where we can. This is not something that has gone away. It may not be in the media so much, but this is something that requires significant investment worldwide. It's one of the many diseases that are circulating, and it is something that is a priority of WHO's.
Can I just supplement because it's not just dengue, Maria. There, as you know, there are concurrent outbreaks of other arboviral, sort of vector-borne or mosquito-borne diseases, including chikungunya, Zika, or push virus. So there are huge drivers now driving a rapid increase in intensity and the impact of many of these arboviral or vector mosquito-borne diseases. That's driven by urbanization. That's driven by lack of management of water and wastewater and standing water in the environment. It's driven by climate change through the increased flooding events and cyclones and others that leave a lot of destroyed infrastructure with standing water around breeding sites for mosquitoes. So there are a lot of social and environmental and climate factors driving this. And on top of that, you've got weakened health systems coming out of COVID. The one thing that dengue does, it's a little bit like COVID for all of you who went through it. Dengue produces a rapid increase in cases requiring short-term hospitalization. Many people are a little sick. Or most people are a little sick. Many people are quite sick and need to go to hospital, and only very few require very intensive intervention. But what it does is it places a massive stress on the healthcare system. Anyone who lives in Pakistan or and countries like Pakistan, Brazil and others that suffer large-scale epidemics and see just how much strain it puts on the system, which means it affects the delivery of other services, other clinical services, because it can bring a whole health system to collapse. We've been managing this collectively across the organisation with our colleagues in neglected tropical diseases as a major global emergency as a grade 3 emergency in our system since December of last year. We've put together a global incident management team and their incident management teams in each of the affected regions. And we put together a strategic plan that needed more than $50 million in order for us to really accelerate activity in this space. We've received no result from those funding requests. And in fact, the Director General, thanks to Dr. Tedros, was able to issue nearly $6 million of contingency funds in order to initiate and sustain our response so far. So again, we're back in a position where we've got a major disease threat, driven by vectors this time, not been transmitted by animals, but been transmitted by mosquitoes, for which we have many interventions that are useful, both at community level. We have very simple clinical interventions that are very successful in reducing case fatality. Good, simple, straightforward clinical care will reduce fatality hugely in this disease. So we have a disease for which we have vaccines and other interventions. And yet, the disease is raging around the world. You talk about 9 million cases. That's what's reported to WHO. We've only really got surveillance in 168 countries. And what gets reported to national governments is a small proportion of the people who are truly sick with the disease. Because what gets reported is very often the more severe cases. So when you think about 9 million, you can certainly add a number of factors to that when it comes to the true number of these cases. So it always amazes me how diseases like cholera, diseases like dengue, are of great interest to everyone, MPOX, and everyone is very intrigued and very concerned about these diseases and how they're spreading and what we can do. And yet, we cannot seem to raise any significant resources or interest amongst governments, amongst donors and others, to actually launch concerted efforts to prevent and control these diseases. It's the ultimate conundrum. A pandemic of influenza will result in a huge amount of resources being made available. COVID did the same. But these old diseases that have been our scourge for centuries, they don't generate the necessary response. And we live with these diseases mainly because these are diseases of poverty. These are diseases that affect poor people in places that rich people don't care about.
Thank you very much, Dr. Ryan, Dr. Vankerkov. We are well beyond 1 hour mark, but we will take one last question from Belissa Godinho from Portugal W Magazine. Belissa, please, the floor is yours. Do we have a Belissa Godinho online?
Hi, do you hear me?
Yes, now we can hear you.
Thank you. Thank you for taking my question. How can you update us on biosecurity and biological risk management in laboratories, improve global health? Thank you.
If I understand well, this is about biosecurity management of laboratories on a global level. So maybe Dr. Vankerkov can say something about this.
Yeah, thanks very much for the question. I can certainly comment on this. So looking at laboratory biosafety, biosecurity is something that is, again, a priority of WHO's. There are many labs that are working around the world that do incredible work related to research, related to diagnostics or PCR-based capacity that help us to understand the circulation of pathogens in countries all over the world. They also support the understanding of the viruses, the characterization of those viruses. It is important that they operate in a safe manner. We have guidance that we have published looking at laboratory biosafety and biosecurity. It's a very thick document in which we support our member states and the labs in countries to operate at the highest level, depending on the type of the work that they do in those laboratories, because there's always the possibility that people can be infected with working with these pathogens. And we're more concerned around the pathogens with epidemic and pandemic potential to make sure that they're handled appropriately within the labs, and all of the people that are working with those labs are trained. Recently, at the World Health Assembly in May this year, there was a resolution that was passed to strengthen even further laboratory biosafety and biosecurity. This is something that we are working right now to implement in all countries. Again, the capacities for PCR-based capacities for research have expanded massively in the last 4 years because of COVID. And this is something, this is one of the legacies of COVID that we want to see sustained. But again, to be able to use these pathogens and do research on these pathogens, it needs to be done in a safe manner. So we will be implementing this resolution that was just passed to strengthen laboratory biosafety and biosecurity in all countries around the world. But this is something for us that is important because there can always be the possibility that people can be infected. There could be the possibility that this can happen in an accident, or there can be a deliberate release. So one of the things that we are wanting to do is to make sure that those who are working with these types of pathogens are working with them in the safest manner possible.
Thank you very much, Dr. Vankerkov. And this will bring us to the end of our press briefing. There were a couple of questions that we didn't have a time to take on, but we hope that you will come again next time. So with thanks to all of you who followed us, a big also thanks to all our speakers who were in the room and online. We will be sending Dr. Tedros' opening remarks and audio file from this briefing later. We will also have a transcript available. With this, I give the floor to Dr. Tedros for his closing remarks.
Thank you. Thank you, Tariq. Hanan, if you're online, do you want to make some closing remarks?
Thank you, Dr. Tedros, for giving me the floor again. I think just reiterating what I said and what you actually have been saying and what we all have been saying, and also to be the voice of all the UN agencies that I met with during my visit, not only to the occupied Palestinian territory, but into some of my other countries. I really hope for peace and calmness to prevail over the countries of the Middle East that are suffering a lot. All the questions that our journalist colleagues have raised on infections, whether dengue, MPOX, and any other type of emerging and re-emerging infectious diseases, they only get worse by the displacement and the unrest and the lack of proper wash and sanitation and hygiene. And these situations continue to pose major risks of transmission of disease around the world. So I hope that we can prevent these diseases from spreading in our own communities and from spreading to, across borders and to other continents. So thank you once again for having me, DG, with you on your presser today, and all the best, and back to you.
Thank you, Hanan, and thank you also, Tariq. And I would like to thank the members of the press for joining us today, and see you next time.